your clinical decision to determine when it's appropriate to test for C. diff. And then I also want to go over some of the pros and cons of various C. diff testing methods and how to interpret the results of two-step testing, which I'm going to introduce to you guys, and how to assess those results and figure out when you should be treating for C. diff. And all of this is going to be through like case-based example. And before I start, I just want to remind everyone, C. diff is spread through a fecal-oral route. So everyone, please, please, please wash your hands. Recently heard that we are worse than orthosurgery. So shout out to our QI team at Harborview for working on this initiative. They have all these cute little signs posted up. All right, so let's get started. Everyone, throw in the chat what comes to your mind when I mention C. diff testing. Oh, geez. Yeah, exactly. I feel like I have had all very similar experiences. I too sometimes think of Hassan when I think of C. diff testing nowadays. But let's start with a question. You have a 60-year-old patient with history of type 2 diabetes, hypertension, GERD, and Parkinson's disease, who was admitted for G-tube planning 1 week ago due to poor PO intake and developed cellulitis 2 days ago. Patient has been on ceftriaxone 2 days ago. So I'm going to take you guys back to intern year. You're the night intern and are paged by a nurse that patient has had 3 loose stools. What do? You can just do the poll. I'll give you guys like 15 seconds. Have people responded, Nikki? Oh, okay. This is great. I'm realizing the poll thing is showing up on my screen share. So the correct answer is actually, wait for the day team. I made this question purposefully vague, mostly to highlight that loose stools can mean so many different things and it doesn't automatically mean C. diff infection. And oftentimes, if the patient is stable, it's actually very appropriate to wait for the day team. So what does constitute as C. diff infection? If it's not just loose stools. The manifestations can range from asymptomatic carriage all the way to fulminant disease. The cardinal symptom, however, is this watery diarrhea that we're all familiar with, greater than 3 loose stools in 24 hours. But the part that I want to highlight is this should be occurring without no obvious alternate explanation. And then other manifestations that you should also look for include lower abdominal pain, cramping, low-grade fever, nausea, loss of appetite. And then there's also this unexplained leukocytosis that some of us may have seen where a patient has like elevated leukocytosis in the high teens, even the 20s, even in the absence of diarrhea, they may be at risk for C. diff infection. So then going back to this patient, you decided to hand off this complaint of 3 loose stools to the day team, and you are now the day team. So I want us to think about what are some external factors that you should consider before ordering a C. diff test. Just throw some things in the chat. What are things you want to think about? Yeah, Joey says bowel reg, so it's tube feeds. Great. Yeah, exactly, Gina. Spot on. How long the patient's been in the hospital. Yeah, all really good thoughts and exactly all things that you should be thinking of. So what I want to do next is actually go through a structured way on how to evaluate for these external factors and what to do if your patient does have them. So specifically, I want to walk through the Occam algorithm together, just so that we all get a better sense of like, when is it appropriate to test for C. diff? And I would really encourage everyone to please download the Occam app, have your interns download the Occam app. It's a wonderful tool. I oftentimes forget it's there, but it's great to use when you're on wards. And right now I'm going to walk you through it. All right, so starting with the first part of the algorithm, first question you want to ask is, has your patient even been in the hospital for 3 days? If not, and say you're like admitting a patient with loose stools, then actually consider testing for more of a community-acquired diarrheal illness. This is probably not C. diff. And in this case, I would encourage you to send an enteric pathogen panel. So patients who come in with this like community onset diarrhea, may have some dysentery, or patients who even have like prolonged diarrhea without an alternate etiology, you can send this enteric pathogen panel. But then say your patient has been hospitalized for more than 3 days, you want to then evaluate for all the external factors that may be contributing to this patient's loose stools. So all things that you guys already said. So are they on a bowel reg? Are they getting oral contrast? Are they on tube feeds? And then lastly, in the last 7 to 10 days, have they gotten chemotherapy? If your patient hasn't had any of those factors, then awesome. It is totally indicated to test for C. diff. But say you're on HEMONC, and I know this happened to me many times on HEMONC, and you've just started a patient on chemotherapy, they start to have loose stools, and the nurse is like, no, we got to test for C. diff because we have to control their symptoms, even though your clinical suspicion is low. I would really encourage you to advocate for waiting to test for C. diff, especially if that patient is very stable. So in terms of like laxatives, take them off the bowel reg, see what happens for 48 hours. If they've just started tube feeds or they've had a change to their tube feeds, you can contact nutrition for bulking options. And specifically with chemotherapy, if they are stable, I would actually encourage you to talk to your phenomenal pharmacist that we have and see if these symptoms are expected chemotherapy regimen related toxicity that you can probably watch. And if that patient really just has diarrhea, they don't really have fever or any other signs for infection, you can actually trial a dose of loperamide. I know that was like a big no-no that we were taught in medical school, but it is on the Occam guidelines. It's actually now okay to do that. Try a dose of loperamide, see what happens for 72 hours before you send for that C. diff PCR. And then if, after observing the patient still has symptoms, then at that point, it's also very appropriate to test for C. diff. I want to acknowledge this pathway has a much longer timeline than what we actually do in reality, and waiting for 48 to 72 hours isn't always feasible. But I just wanted to get you guys thinking of this because it's really important that we test appropriately for C. diff, and you kind of think through those external factors that can be contributing to loose stools before you order that test. So just like a screenshot slide, Occam pathway key takeaways. If your patient has loose stools, they haven't been in the hospital for more than 3 days, it's probably community acquired, order an enteric pathogen panel. If they have been here for more than 3 days and they're having loose stools, evaluate for external causes, like we just talked about. Laxatives, oral contrast, tube feeds, chemo, how long have they been on antibiotics? If they don't have any red flags, there's no concern for systemic signs of infection, they're afebrile, they're very stable, you can observe for at least 48 hours and you can actually trial some Imodium. And if you've tried all of these steps and the patient still has diarrhea, it is okay to test. So with that said, we're coming back to our patient who had the 3 loose stools. You're still the day team and you do a little bit more digging and you realize patient got PO contrast yesterday for his G-tube planning, and he actually started tube feeds this morning. So just throw in the chat, quick or no, would you test this patient for C. diff? Yeah, great. You would. Does anyone, someone brave in the chat, want to walk me through their reasoning for why they would not test for C. diff?
Basically gave him a big laxative.
Yeah, exactly. You guys are spot on. So patient got oral contrast in the last 48 hours. They literally just had tube feeds started. And even if you were thinking, this patient has gotten antibiotics, but it's only 2 days, there's not really like a hard and set rule about how many days of antibiotic therapy increases your risk for infection, but like typically it ranges from anywhere from like 3 to 14 days of therapy. And then after you're done with antibiotics, you can also see it about 5 to 10 days after therapy is done. And typically the antibiotics you're worried about are like penicillins, cephalosporins, fluoroquinolones, and clindamycin. So just to summarize, in this patient, I would encourage you to watch and observe before you send for that test. So then I want to kind of move into the next part of my talk of seeing like how well have we been following this Occam algorithm? That tool exists, but are we really using it? I'm going to show you guys some data, so just bear with me for a second. This is our specifically UW-MC's hospital rate of C. diff infection. So I'm going to walk you through this graph. It is looking at our rate of C. diff infection longitudinally. So the x-axis is looking at the rate over time, over the last year, basically. And then the y-axis is looking at the rate of C. diff infection in percentages. The dotted green line is the target goal that is set internally by the hospital. And as you can see, we are consistently above target. Really just wanted to show this slide to say like our rate of C. diff infection is consistently high. And so then you're like, why does that matter? Why do I care if the hospital is above goal? Well, it's important to think about, whether that graph I showed, like whether this graph really represents true C. diff infection. Is that really the rate of our C. diff infection? And that matters specifically for patients because, sorry, Andrew, or Ananya, the hospital sets the goal internally. It's based on a bunch of different criteria, and I'm happy to put in the chat later on at the end of my talk, the different criteria. And this matters because for patients, if we are not accurately representing our rate of C. diff infection, falsely high rates of C. diff infection can lead to unnecessary treatment, unnecessary isolation for the patient, unnecessary expenses. And then for hospitals, this is also a publicly reported patient safety metric. And so high rates can also result in financial penalties for the hospital. So this is really like the bulk of my talk is looking at why are our C. diff rates so high? And I think when thinking about this question, there's like two main factors that we have to really examine. Number one is, are we testing appropriately? And the second is, are we using the appropriate testing methods? So let's start with, are we testing appropriately? This is another graph. The short answer to my question is no, we are not testing appropriately. We are testing way too much. And this data is actually something that you guys are going to be seeing on the medicine, cardiology, and hem-onc floors in the coming months. It's part of a scorecard that is going to be presented to all of the teams. The graph itself, the y-axis is looking at the number of orders. The x-axis is looking at this data longitudinally over quarters. And then the yellow represents the number of negative PCR tests, and the purple represents the number of positive tests. And as you can see, there is a whole lot of yellow on this graph, mostly to say that a majority of the tests that we order are negative. So for example, in 2021, we ordered a total of 108 tests, and only 13% came back as PCR positive. So basically, we're over testing. Just to give you guys a little bit more information on the scorecard, the scorecard is going to have this quarterly data presented to you, just how you saw that same graph, in addition to the Occam guidelines and some like kind of suggestions on how to test appropriately for C. diff. Once again, it's going to be presented to the medicine, cardiology, and hem-onc teams. I think it'll be in like the next few weeks that you guys will start getting that. And the goal of this scorecard is really to look at our ordering practices and provide staff with feedback regarding their testing habits. We're hoping that with these scorecards, we'll kind of bring awareness on how to test appropriately, and hopefully we'll get a number of higher percentage of positive tests. So we're hoping that overall the graph will be more purple. Ananya, that is a wonderful question. And we don't really have a goal percentage positive currently. We don't know like what the correct number of tests to order is yet. This is a pilot study, and the point is really just to see if this intervention improves awareness and it does change our testing habits. So how can we improve? Follow the Occam guidelines. Really highly encourage you guys to download Occam, wonderful tool. Monitor closely for side effects of medications, especially when you're on the hemonc floors, and work closely with your pharmacist. And then also keep a broad differential. I think sometimes we get boxed into thinking that someone has C. diff, but I would encourage you to also think about other causes. And, you know, like I said, ultimately, we're hoping by using these strategies, providing you guys feedback, we'll be able to reduce over-testing rates, and then also decrease unnecessary treatment and isolation for patients. And so then bringing it back to like my original question of like, why are our C. diff rates so high? As you saw, we are chronic over-testers, and we don't always test appropriately. But then the second branch of this is, are we even using the appropriate testing methods as an institution? Right now, all of the hospitals, and I want to focus specifically on UW-Montlake, we use PCR alone as our testing method. And I don't know if it's the best testing method. So I want to first start with a question. I'll give you guys like 30 seconds to a minute to answer this one.
Sorry, I forgot to launch the poll. Give me a second.
Oh, that's okay.
Maybe we can give it 15 more seconds.
Okay, yeah. Great. I think almost everyone got B. I do want to talk to what the other testing strategies are. And so I want to go over some testing methods for C. diff that you may or may not have heard of. The ones that I have up right now are not commonly seen. The cultures can be great for testing, but they just take a really long time to come back, so we don't really use them. The glutamate dehydrogenase enzyme immunoassay has a quick turnaround, but because the specificity is so low, it can't really distinguish between active infection and colonization. And the only time I've really seen this test being used in the literature is in combination with other tests. The PCR test is what we currently use and what we're most familiar with. But the difficulty with PCR is that it has such a high sensitivity that it doesn't really test for active toxin production. And it can be really hard, once again, to distinguish between, does this patient have active infection or do they have colonization? And one of the pitfalls of using the PCR test is that it can lead to, overdiagnosis of C. diff infection, which can then in turn lead to overtreatment of patients, delayed diagnosis of other causes of diarrhea, and then just falsely elevate our hospital-associated CDI rates. On the other hand, the toxin enzyme immunoassay has a really high specificity, and this is what really can be helpful for distinguishing true C. diff infection. So what are the current guidelines? Like, what is the best way to test? The IDSA, the Society of Healthcare Epidemiology, the European Society of Clinical Microbiology and Infectious Disease, like the big, three trifecta of ID guidelines, all really now recommend this two-step testing method. And what this entails is you start with a highly sensitive test, so the NAT or the PCR, like we just saw, and then you kind of follow that with a more specific test like the toxin immunoassay to help really distinguish between true active infection and colonization. And we're going to talk about how to interpret the results of two-step testing in a later part of my talk, but I just kind of wanted to give you guys a framework for what is two-step testing. And before we get there, before we get to interpreting the results, I want to just talk a little bit about why two-step testing is actually really beneficial. It can provide additional information about toxin production to help, better inform our clinical decision making. This allows us to distinguish between active infection, asymptomatic colonization, and avoid unnecessary treatment in patients. It can also help broaden our differential and promote evaluation and management of other causes of diarrhea. And lastly, it can reduce overreporting and hospital-associated C. diff. So to further convince you that two-step testing is really great and that PCR testing alone is not so great, I want to walk us through two studies, so just bear with me while I go through this. So this first study basically shows that PCR testing alone can lead to overdiagnosis. So this study looked at how clinical outcomes compared between patients that were PCR positive, toxin negative, and PCR negative, toxin negative. And what they found were that when comparing these two groups, patients had similar outcomes. And what this goes to show was that the PCR test result, whether it's positive or negative, did not have clinical significance and it did not change clinical outcomes. However, when then looking at patients that were toxin positive, patients had a lot more severe symptoms, and actually the complications that any of these patients had were in toxin positive patients. And I think this goes to highlight that the difference in clinical outcomes is more related to toxin status rather than PCR. And that it really drives home the point that C. diff is a toxin mediated disease. So just the PCR alone is not helpful. And it can actually represent colonization rather than infection. And what you really need is that toxin data to help you distinguish between true infection and colonization. Also, if anyone has any questions, please put them in the chat. I know talking about studies can always get really complicated. The second study I want to go through, also bear with me, basically is showing that PCR testing alone can lead to overtreatment. And so this was a really interesting study that looked at 600 patients that were all PCR positive, toxin negative. They were split into two groups based on what result was presented to the physician. So basically, one group had only the PCR reported, and that is the only thing that physicians saw. The other group of patients had only their toxin negative result reported, and that's the only thing that physicians saw. The physicians were not told whether or not to treat the patient based on the test results, and they were kind of left to their own clinical judgment. What this study wanted to look at was, one, does the testing reported affect outcomes? So if you report PCR or toxin, how does that affect outcomes? And then how do we interpret these results? And what they found were that in patients with only PCR positive result reported, the physicians decided to treat 91.5% of these patients. However, in the patients that only had that toxin negative reported, physicians decided to treat only 15.1% of these patients. And I think that this data highlights that sometimes we reflexively treat without really critically thinking about what the results mean. And yes, Adrian, we're talking about the toxin gene PCR, like the NAT test that we often order, versus the toxin report is the toxin enzyme immunoassay, which we currently do not use. So I think sometimes, and I'm sure we've all done this, where we see PCR positive and we just instinctively treat without really clinically thinking about what that result means. And so I think one of the big takeaways from this study is that testing that's focused on that toxin status can lead to reduction in antibiotic therapy compared to just PCR testing alone. There was a giant reduction, 91% to 15% comparison. And more than that, this study looked more closely at clinical outcomes. And what they found was that despite this difference in antibiotic therapy, so 91 to 15%, there was no difference in diarrhea symptoms at 7 days or in 30-day all-cause mortality. So I think this study, one, makes you think critically about, like, do we need to treat patients that are PCR positive, toxin negative? And then it also really drives home the point that just focusing on the PCR positivity and PCR testing alone can really bias us and lead us to overtreatment. And so I hope these two studies kind of convince you that two-step testing is beneficial for really distinguishing true infection. And so in the coming months, you guys are going to see a whole new set of results. Two-step testing is going to be coming to UW-Montlake, only UW-Montlake specifically, around December, January. And so you'll see both the PCR and the toxin report results reported at that time. You are going to order the PCR just like normal, and if it's positive, it'll automatically reflex into that toxin enzyme immunoassay. Yeah, so be on the lookout. Both Prashanthi are pretty fast, and so it should not delay patient care significantly. The results will come back within 1 to 2 days, and honestly, maybe even faster. I'm curious to see, I don't know anything about the lab protocols or like their turnaround time, but it'll be really interesting to see. And why all not hospitals? That is a great question. And I think there are a lot of different stakeholders in this project. And so currently we are just piloting it at the one hospital. So keep an eye out for this. It's not going to be at Harborview. It's just going to be at UW-Montlake. So now that we've talked about this, now that you know it's coming, how do you interpret the results of this two-step testing? Because we're going to have to do it in the next upcoming months. So I want to start off with a case. You have a 79-year-old patient this time. He has a history of hypertension, hyperlipidemia, head and neck squamous cell cancer. Patient has been getting inpatient treatment with chemotherapy and radiation for the last 2 weeks. He is also status post PEG tube 1 week ago, and he's now having greater than 3 watery stools. Like the stellar resident you are, you pull up your Occam protocol. You make sure that there's no other explanations for this patient's diarrhea. He doesn't have any, there's no bowel reg, there's no changes to the tube feeds, no oral contrast. You check with the pharmacist, and chemotherapy agents don't have any side effects of diarrhea. And patient hasn't been on any like prolonged antibiotic treatment. So you decide it's appropriate to test for C Diff, and you test using the new two-step protocol, and you send for PCR. That PCR is positive, and then it's reflexed into the toxin enzyme immunoassay automatically. And that's the result you get. How many of you would treat this patient? Just put it in the chat. Yes, no, I don't know. Let me know what your thoughts are. Wow. Yeah, okay. I will help you, McKenna. So this is actually a really complicated topic. I want to go over just algorithmically how to interpret the results of this two-step two-step testing. For patients who are PCR positive, toxin positive, they likely have C. diff infection, but of course you should correlate with clinical symptoms, make sure that they actually have those manifestations of C. diff that we talked about in addition to just that watery diarrhea. And these patients, you're most likely going to end up treating. In patients who are PCR negative, toxin negative, they don't have C. diff, you shouldn't treat them, and I would encourage you to look elsewhere for an explanation for their symptoms. And then there's this middle category with PCR positive, toxin negative, and there's actually a lot of conflicting data regarding this. And the reason is because with these test results, it's still really hard to tell if patients have symptomatic acute C. diff infection or they are just colonizers. And that's because that toxin is negative. So it can be really hard to figure out, do we treat this patient? So what do you do with this result? And that's what I kind of want to dive a little bit deeper into. So to treat or not to treat, that is the question that a lot of studies have been trying to answer. And so I kind of want to just present two quick studies and show you that there's really conflicting data out there. So when comparing outcomes between patients who are PCR positive, toxin negative, who are treated versus not treated, I already showed us one study with the two groups that were split based on what part of the result was reported and the physicians had to decide. That study found that there was absolutely no difference in 30-day mortality in this patient population when you treat versus you don't treat. However, there was another study, and there's several more that show, patients with treatment had a lower 30-day mortality rate. So how do you know when the patient has like a true infection and when we should treat? And unfortunately, there's no really right answer. And I think what it comes down to is that C. diff is ultimately a clinical diagnosis. As much as these lab tests can guide us, we really need to use our clinical reasoning and judgment to decide if treatment is appropriate for patients who are PCR positive, toxin negative. But I do want to give you guys some tools to help inform this clinical reasoning and when your suspicion for true infection might be increased. So this was a retrospective study that basically looked at like PCR positive, toxin negative patients to help identify clinical features that were associated with C. diff related complications, mostly to help identify those with true disease. And what this study found was that patients who had these features, so fevers, PPI use within like the last 4 weeks, baseline severe disease, baseline fulminant disease, these patients with these features had an increased odds of developing CDI-related complications. So all this to say that these criteria can potentially help kind of guide your clinical reasoning when trying to decide whether you should treat a patient that is PCR positive, toxin negative, and raise your suspicion for a true infection. And I also just kind of want to take like a sidebar here and remind everyone quickly what classifies as severe infection versus like fulminant colitis. And so C. diff is kind of split into 3 severities. You have non-severe disease where you really just have that diarrhea and fever, but you don't really have any lab abnormalities. So there's no like super elevated leukocytosis, your creatinine is fine, you're more or less hemodynamically stable. But then severe C. diff infection is when you do have an elevated leukocytosis, you do have that elevation in your creatinine. And then fulminant C. diff infection is when we worry about the big bad scary things, so like hypotension, toxic megacolon, ileus, or you find it endoscopically and you see there's consistent findings with colitis. So that was just a quick reminder, and just again, the severe and fulminant disease severities were really the ones that were associated with more C. diff related complications. So coming back to this slide, there's no really right answer of whether or not we should be treating PCR positive, toxin negative patients. Really what it comes down to is using clinical reasoning when deciding what to do. If, is the patient febrile? Do they meet criteria for severe or fulminant C. diff infection? Like, what is our suspicion for true infection? And if after all of that you are still confused, as I'm sure a lot of us will be, it is always okay to ask for help. And I would encourage you to page ID for help. All right, so I want to just end my talk with one last case, and then I can go through and answer some of the questions in the chat. You have a 72-year-old, history of HEPRA, hypertension, CAD, who was hospitalized 2 weeks ago for complicated pneumonia. Patient has now developed 2 days of watery diarrhea. You look at the vitals. Patient is febrile, 39 degrees Celsius. They have a heart rate of 112. They're tachycardic. Blood pressure is normal, and they seem to be satting well on room air. Their labs show a BMP with potassium throughput 1. They have a creatinine 1.9 and a leukocytosis of 18K. You look for any alternate explanations for diarrhea. There are none, so you decide to send for C Diff testing. And that result comes back as PCR positive, toxin negative. So in this patient, would you treat them? You can just put in the chat what you think. Yeah, and I think this case really just goes to highlight that, you know, this patient meets criteria for severe C. diff infection, and you should treat this patient. And this is, you know, one of those cases where you use your clinical judgment, your reasoning to test a PCR positive, toxin negative patient. So some of the key learning points, I just want to end with these, is that C. diff infection is watery diarrhea with no obvious alternate explanation. And I want you guys to use Occam to help evaluate for these alternate explanations and help guide appropriate testing. The 2-step testing algorithm is coming soon to UW-Montlake, and it involves a PCR test with an automatically reflux toxin enzyme amino assay. And this 2-step process can really help distinguish true infection from colonization. And then when interpreting the results of 2-step testing and trying to decide when to treat, remember to use clinical reasoning, reach out to ID. But ultimately, you know, C. diff infection is a clinical diagnosis and can be really challenging. And that was it. Also, another reminder, everyone, please wash your hands.
Rajuta, that was awesome. Something I love about these deeper dives into things that we think about all of the time is like essentially what Gina said in the chat, which is that I'm always surprised at how much more nuanced many of these decisions are. And as you were talking, I was thinking like, how do I also communicate this with nurses or family members that are like, we need to test, and to think about how can I advocate for kind of the overall systems level factors, which is really interesting to reflect on. I'm not sure if you have other thoughts, John.
No, I think it's great. I think it's always fun to see something that is we think is basic, not actually turn out to be basic. I put it in the chat, but I actually calculated some numbers just for fun, just because I'm a total geek. If you this whole idea of like starting with your pretest probability, like how much do you think this person actually has C. diff versus my attending's getting me to do it because I don't believe it, but we're doing it anyways. If you started off with like a 75% chance that the person actually has C. diff, had that sequence where it's the PCR is positive and the antigen is negative, after all of that, your post-test with those 2 tests is still 90% chance. So if you're starting off and saying that the chance is 75% that they have it, you've gone to a 90% chance, and that's why you have to use your pretest probability. If you take the other extreme and say there's only like a 20-25% chance, in that sequence, I calculated it out, you're still at the end of that, still with a 60% chance that the person actually has C. diff. And so that original, like, what's the clinical story, matters so much for that interpretation of that, like, positive PCR, negative antigen, which is confusing. So long-winded way of saying, yeah, consider the patient. Sorry, I
Yeah.
just had to geek out and do numbers for you.
No, thank you very much. That is actually really helpful. I am quite honestly horrible at statistics, and so I really appreciate you running the numbers, John. It really does put it into perspective of how to use your pretest probability. And I also want to just clarify some of the things in the chat. So Adrian, the test you're going to order is just our normal PCR test that we have been ordering. From our perspective, it changes nothing except for the fact that you now might be getting this new toxin result that you should know how to interpret, but you just still ordered the PCR test. And then I think maybe there was another question. Maybe not. Oh, but I did want to reply to you, Nikki. So this is a pretty big project, and like I mentioned, it has a lot of stakeholders. And so one of the stakeholders is actually also nursing. And so there's been a lot of discussion regarding nursing education. With the scorecard, you are also going to get a chart for the Bristol stool scale, and that can also help kind of guide nursing and you to talk about like, well, is it just loose diarrhea or is it like really watery? And then also, I think having this more updated Occam algorithm being presented to everyone will hopefully make it easier for you to advocate to not test your patient, you know, in the setting of another alternate explanation for their diarrhea. Any other questions, you guys? Thanks for listening.
Thank you so much. Let me stop the recording.